This is chapter 14, Pharmacology and Medication Administration. So just a few terms you need to know before we get started here. So the first one is indication. This is the reason why we give a medication. So if someone's having chest discomfort, we think it's cardiac related, then that's an indication for providing the patient with nitroglycerin or possibly aspirin. When it comes to contraindications, this is the reason why we cannot give the medication. Even though the patient's having chest pain and we think it's a heart attack, and it's their medication and they normally take it, their blood pressure now is too low, so we cannot give them their or help them with their nitroglycerin because the blood pressure will be a contraindication. A dose is the amount you give each time you administer a medication, and that varies depending on the medication. So you need to know your dosing and based on the different drugs that medication you're able to administer. When you do administer a medication, there's two ways of administering it for EMTs. If the medication is something that you as an EMT carry on your rig, so you're a firefighter EMT, you're an EMT on an ambulance, you're a rescue EMT, you're a lifeguard EMT, you have the medication, it's in your kit. It could be epinephrine, it could be Narcan, oxygen. Those are all provided by direct administration. If the medication is something the patient has themselves, so nitroglycerin, aspirin, metered-dose inhaler, those types of medications, they have them on them. They're their medications. You can only assist with the medications that the patient's prescribed. Actions are the positive effects of each medication, and we should be aware of the actions, how each medication works, and what we're going to see or be able to evaluate after the administration. For instance, nitroglycerin, its action is vasodilation. So we know that this process of vasodilation relaxes the heart, makes the heart work less forcibly, and should reduce their chest discomfort. So if you give or you assist with a dose of nitroglycerin and this person's blood pressure drops a little bit, because obviously the vasodilation would do that, and also they feel better, that the positive effects are working, the actions are happening. Pretty much most every drug also has side effects, and these should be informed to the patient. That you should tell the patient, I'm going to help you with your nitroglycerin. You realize you might get a headache from this. With the aspirin, you might get upset stomach with this. If you're going to administer epinephrine, you might get jittery, or your heart might start pounding. Those are all side effects. They're expected side effects. You should probably pre-warn the patient prior to administration, if you can, that they're going to feel these things, so they won't get scared by or be upset by the process. Standing order is a situation where you can administer a medication either directly or by an assist without having to call the base hospital, as long as all the parameters are met. If you do need to call and get an order online, that's a base hospital order, maybe for an additional dosing of a medication or certain circumstances where it is a base hospital order. Pro re nata is PR. It's PRN. So if you see a medication in the protocols that says provide to the patient PRN, it just means you can just keep giving it as many times as you need to without, basically on standing order. There's 8 medications that EMTs may either directly or indirectly administer: aspirin, charcoal, oral glucose, normal saline, oxygen, Narcan, epinephrine, and nitroglycerin. So the first one, aspirin. So aspirin is an antiplatelet aggregate. So essentially what it does is when a clot is developing in the person's heart that leads eventually to this, heart attack, by taking an aspirin every single day and preventing the clotting cascade from allowing the thrombin and the fibrin from sticking together and throwing out these little fibers and creating this fibrous clot that leads eventually to this clot that causes the chest discomfort. So this reduces the chance of this clot developing any further, or reduces the chance of it developing at all. It does not break up clots, it just prevents clots from developing or getting worse. This is why people who take aspirin every day, people who have a high risk of stroke or heart attack, they have other diseases that make them high risk. The doctors told them to take an aspirin a day. It's going to be their aspirin. They're going to have it themselves at their house or on them. The indication is any pain or discomfort of a cardiac origin. So you think this person, however they're presenting, you think this is cardiac related, you can assist with this on standing order. The only contraindication is that the person has an allergy to the medication, which they probably shouldn't, but you need to ask anyway, just in case, because people are like that. You just never know, and it's on you if you give this medication, even though you're assisting them and they're actually putting it in their own hand and they're swallowing it themselves. It's on your documentation. Your name's on this. You should make sure that there's no contraindications. There are some side effects with this. So nausea, so gastrointestinal upset. And if they have ulcers, and they should know they have an ulcer, they're probably pretty aware of it. This can increase the bleeding of the ulcer. So they might say, I stopped taking aspirin because I have an ulcer, and that's fine, whatever they want to do with that. The dosing is between 81 and 325 milligrams, chewable tablets. Usually people take 1 or 2 81 milligram tablets every day to maintain a therapeutic dose to reduce the chance of those blood clots forming. The amount that you're going to assist with is their normal daily dose. So if they said, I took 2 baby aspirin this morning when I had breakfast, and now I'm having chest pain, you would assist them with an additional 2 81 milligram tablets. So whatever their normal dose is, that's what you assist them with. That's what you document. That's the standing order in the County of San Diego for EMTs. Now, charcoal is not in your scope of practice in the state of California. Now, charcoal, it's a thick liquid. It comes in a tube or a bottle. Its actions, essentially what it does is it's called activated charcoal. So it goes into the gastrointestinal tract. This person drinks it down and it gets into their stomach and into their small intestine and even their large intestine eventually, and it binds everything to it. So whatever nutrients, whatever poisons, whatever toxins are in this person's gastrointestinal tract, it binds and it prevents those products from going out through the wall of the intestines and stomach and getting into the bloodstream. Indication is an oral ingestion of a poison or overdose. So this is a person who wants to die and they took a whole bottle of sleeping pills, or this could be the person who inadvertently took medications or too much medications and they ingested it. Now, contraindications are many. Isolated alcohol. So the abbreviation for alcohol is ETOH, is ethyl alcohol. It's what beer, wine, whiskey, those types of things. It does not bind to the charcoal, so it doesn't get you less drunk, essentially. Heavy metals, this would be lead or cadmium or mercury. Again, it doesn't bind. Caustic agents, this would be something like Drano or battery acid or pool acid or something base or acid product that they ingest for various reasons on purpose or by mistake. The problem with this is that as this person swallows the battery acid, it scars and damages their esophagus, and now it's in their stomach. So if we go and we have them drink the charcoal, the number one side effect of charcoal is vomiting. And the concern is if they vomit up all that acid, it's going to go back up the esophagus and burn the esophagus even more. And you can see that it can cause more damage to their esophagus. So again, we'd want to hold off on that. Hydrocarbons, this is gasoline, those types of products, kerosene, paint thinner, those types of products. Iron ingestion, there's tablets, iron tablets that females take for anemia when they're having their period, or older females as well. So they're literally these little tablets. They're colored, they're sweet, and sometimes little children will think they're whatever candy, and they'll ingest large quantities of them, which is really dangerous, even life-threatening. But again, unfortunately, charcoal does not bind to iron ingestion. Uncooperative, going back to the person who took the sleeping pills to try to hurt themselves. You tell them, drink the charcoal, it will make you live, allow you to live. They're going to go, nah, I don't want to live. So you can see uncooperative might be an issue. Unaltered mental status. So the big concern here is that if you think about when you eat something, when you have your lunch or dinner, it gets into your stomach, and it takes a while for that food to break down to the point where it's allowed to be absorbed across the wall of the stomach into the bloodstream, and the nutrients and the sugars and all that. Same thing with poisons, and the same thing with pills and things like that. It takes a while, 30, 40, 50 minutes, an hour, or sometimes even a little greater, before medication breaks down to the point where it can be transferred across into the bloodstream. So we do not want to provide them with charcoal if the ingestion of whatever they took is greater than 1 hour since that ingestion. And the reason why this is because more than likely the medication is in their bloodstream now, and it's probably affecting their central nervous system. So you're probably going to see confusion, sleepiness, altered mental state, weakness. Their vital signs might be changing, their blood pressure might be dropping or rising. So you can see now the medication's already out into their system. So we don't want to give it at this time, because if you think about it, if you think the number one side effect is vomiting, if you had somebody drink a whole bottle of charcoal, then they went unconscious, and then they vomited, they're not going to be able to control their airway. That food product, the pills, whatever they took in their stomach, plus the charcoal, is going to wind up probably in their lungs, which is really, really life-threatening. So again, they have to be awake and alert and cooperative. They have to have a gag reflex, obviously, and it has to be less than 1 hour since ingestion. The dose is 1 gram per kilogram of body weight orally. The max dose for adults is 100 grams. And the max dose for children is 25 grams. Please involve poison control, meaning call poison control. And here in the state of California, and I believe it's nationwide, it's 1-800-222-1222, which is the phone number for poison control. They're there 24 hours a day. Explain to them what the person ingested, how long ago they had ingested it, and of course their symptoms and all that, and they can tell you whether or not to give the charcoal, or maybe something else, something household product like milk or water might neutralize things. Just remember, it's not in your scope of practice here in the state of California. Oral glucose, it's essentially dextrose, it's sugar, and silly, but it increases blood sugar levels. Indications would be an altered level of consciousness, LOC, in a known diabetic patient. This would be a call where you get called to a private residence. Possibly the wife calls because her husband's acting bizarre, acting weird. And you get there and the wife says, my husband's a type 1 diabetic. He took his insulin this morning and he didn't eat. He's awake, he's cooperative. He's a little confused, he's a little sweaty. You don't have to get a blood sugar on this person. You don't have to prick his finger and draw blood and get a blood sugar reading. He's a known diabetic. He's acting funny. He's cooperative. you can administer the oral glucose on standing order. That's given orally. If you have somebody who's not a known diabetic, or you don't know if they're diabetic or not, and they have an altered mental status, then you would get a drop of blood and you would get their blood sugar level. And if it's below 60 milligrams per deciliter, then you can administer the oral glucose, as long as they're not unresponsive or uncooperative, and they have to, of course, have a gag reflex. The dose is 15 grams. This is for adults and children. It's 1 tube per packet. It's kind of a liquid goo kind of substance, or three tablets. Each tablet's 5 grams, so 3 tablets, 15 grams. And this is a standing order in the County of San Diego. Now, normal saline, we carry these little ampules, little pink ampules. They're 2.5 milliliters per ampule. You'll have them on the ambulance, the EMT ambulance, or the fire truck, or the rescue vehicle. And essentially, it's just water and electrolytes that mimics the same body composition for our chemistry. And this is for either adults or children who are having a croup-like event. This is the croup-like cough. They got a low-grade fever. They got this barking cough. They've had a recent cold or flu, but they have this high-pitched cough going on. It's a standing order in the County of San Diego. You can administer at PRN. You can administer as long as just keep giving it all the way to the hospital. So you take 2 of those pink vials, so a total of 5 milliliters. You squirt them into those little medicine chambers. You see up in the pictures there, right below where the nebulized T is. There's that kind of cup there. Same thing you see on the mask on the right side. You squirt in basically this water and electrolytes. You administer either through mask or neb-T at these flow rates, 4 to 6 liters for the neb-T, which is the one on the left, and the 6 to 10, which is the neb-mask, the one on the right. Again, this is PRN. You can keep giving it all the way. What it does, the medication gets back there, it's humidified, it relaxes the back of the throat, it opens up the back of the throat, and it makes them breathe better, and it gets rid of that cough, that high-pitched cough that they have. Now, oxygen, you've been through a lot of classes with this. You've had lectures and tests, and I'm sure you probably had a couple labs by now. Just remember that this is a medication. It's prescribed, meaning that a doctor has to sign a prescription for your agency, your fire department, or your ambulance service, or your lifeguard service to administer oxygen on standing order. It does have some, negative effects. I know you learned about people who are having strokes, people who are having cardiac events. We're concerned about vasoconstriction. So we don't want to over oxygenate them. We want to maintain that 94 to 98% levels using whatever means. A cannula at 2 liters, or a mask at non-rebreather at 15 liters, whatever works to get that range going. When we're dealing with people who were in cardiac arrest, and let's say you shock them with your AED out of cardiac arrest, and now they have a pulse. We're also very concerned about those people as well, because they have quite a bit of tissue damage, quite a bit of free radical release, and if we give them too much oxygen post resuscitation, it can cause this cascade effect, which can cause more swelling and more tissue damage and more organ failure. So again, we want to keep that 94 to 98% range on these patients if we possibly can, in whatever means you do it, cannula, mask, BVM, however it works. You're going to try to maintain that lower oxygen level. There are some patients who benefit from high oxygen levels. A patient who's pregnant, who's injured or sick, definitely want to get them 98% or above, possibly. Someone who has critical injuries with blood loss, definitely want to get their oxygen saturations above 98%. So high flow O2 is not a problem, because they're losing their ability to carry oxygen, so we're trying to compensate for that. Also, if someone is severely short of breath and they're showing signs of severe hypoxia, We want to get them their saturations as high as we can. So high flow O2 possibly. It's going to be your choice. It's going to be your decision on this. Um, and every patient is a little different. And this is the critical thinking aspect of the whole thing, is what's going to work for this person. Try one thing and that doesn't work, try something else. Epinephrine. So this is pure adrenaline. And we know the adrenal glands make epinephrine, and it's alpha and beta products in the adrenaline. The indication for the medication is anaphylaxis, and the definition of that is a life-threatening allergic reaction, which means this has affected their cardiovascular system. So maybe, maybe they have vasodilation going on and low blood pressure. It can affect the respiratory system, causing bronchospasm and wheezes and difficulty breathing. It can cause swelling to their face, their tongue, their throat, making difficulty breathing. So the actions of epinephrine is it's a bronchodilator. So that's your beta 2. It's a vasoconstrictor. That's your alpha 1. And then if you combine the vasoconstriction properties with your beta 1 properties, which increases contractility of the heart and makes the heart beat harder and faster. If you put those two together, that increases their cardiac output. Side effects. Again, you should, if you have time, if they're super critical, then I wouldn't worry about it. But explain to them they're going to feel anxious. They might feel palpitations, like their heart's beating out of their chest. They might feel really shaky when this is administered, because it is epinephrine. The dose. So you may directly administer. You will be trained to do this when you leave the course. You'll be licensed to do this. You'll have it on the ambulance or fire truck or rescue vehicle or a lifeguard vehicle. Now you can see the dosing is kind of funky. It's weight-based. So if someone is equal to or greater than 33 kilograms, which is around 73 pounds, you give the full adult dose of 0.03 milligrams. It's given intramuscularly, IM, in the lateral thigh, left or right, whatever the patient prefers or you prefer. If they weigh between 15 and 33 kilograms, which is 33 pounds to 73 pounds, they're given the half dose pediatric dose, the 0.15 milligram. If they weigh less than 15 kilograms or they weigh less than 33 pounds, you cannot administer it. It would be a contraindication. You'd have to call ALS, call paramedics, have them come out and have them dose the patient based on body weight. They can drop the medication themselves and dose it out individually. So you need to know what this person weighs to decide which dose to give or whether you can give it or not. And of course, it's a standing order for your first dose. If you need additional doses, it'd be by base hospital direction. Now, naloxone hydrochloride, or Narcan, it's an antagonist, an opioid antagonist, and essentially what it does is it blocks the receptor sites or occupies them, so the opioid is not able to attach, and it reverses them. Indications: so symptomatic narcotic overdose with a respiratory rate less than 12 breaths per minute. It doesn't say anything about altered mental status, doesn't say anything about pupil constriction. All it says is this person is not breathing effectively in some way. And we give Narcan to drive the respiratory. We do not give Narcan to wake them up. It's not our purpose. Sometimes it happens as a side effect, I guess. But we want to give this medication because we're concerned about their breathing. Now, again, this is also weight-based as well. So if this person weighs equal to or greater than 35 kilograms or around 77 pounds, it's a standing order. Either the 2 milligram version, the one above you there, the kind of the salmon colored one there, or the 4 milligram preload, which is the red and white box with the little nasal sprayer thing. More than likely, as an EMT working on an ambulance or fire truck, you're probably going to have the upper one there, that naloxone box up there. It's easier to administer It's for us because we can control the dosing, whereas the sprayer, the lower one there, it's one time, one shot. You give the whole dose. You can't control. You can't titrate it in any way. It's given intranasally, so up the nose. Side effects. Number one side effect is acute withdrawal symptoms. You think about it this way: this person has somehow ingested some type of opioid, narcotic. They're not feeling any pain. Now, whether this is by accident, maybe they're a comfort care patient because they have chronic pain, they took too much pain medication, or maybe they did it recreationally. It doesn't really matter. They're unconscious, they're not breathing. The funny thing is they're happy as a clam right now. They're not feeling any pain. You go and administer this medication, you wipe out their opioid high, and they're going to wake up in agony. And this is why they wake up screaming and aggressive and combative, because it hurts a lot. They're not mad at you. They're in pain. They're disoriented because of what went on, and they see someone in front of them, and they start wailing on you. So it's really important to be prepared for this. Administer the Narcan. Just stand clear. They might wake up. They might wake up mellow. They might wake up combative. So just be careful for everything here. They'll also vomit. They'll urinate. There's all other kinds of things going on here. So this is a standing order for direct administration. You will be trained. You'll have this medication on your ambulance. You'll have it on the fire truck. And hopefully your instructors have covered the proper administration of this, the actual devices and how they work and how you administer them and all that. Nitroglycerin. So this is a vasodilator, and its indication is exactly the same as with the aspirin: pain or discomfort of cardiac origin. And it vasodilates all the arteries. So if you think about it, if you have if you have a system of arteries that get bigger, so the container gets bigger, and it's the same volume of blood, the blood pressure is going to drop, or lower anyway. What this does is less blood comes back to the heart. So the preload, as you remember from your A&P day, hopefully, preload is the blood returning back to the left side of the heart. So it's the blood that pours into the left ventricle prior to contraction. That's the preload. And then the afterload is the amount of pressure your heart pumps against in the actual arteries themselves, the aorta, essentially. So if you reduce the preload, if less blood is getting back to the left side of the heart, less blood is being pumped out into your arteries, then that's actually lowering the amount of your blood pressure, right? And what's happening is that your heart doesn't have to pump as forcibly or as powerfully, so it needs less oxygen. So it reduces the workload of the heart, and it reduces the oxygen consumption of the heart. So the heart needs less oxygen. It's working less forcibly, so it calms down. And because of this, the oxygen demand of the heart is reduced, and so will their chest discomfort as well. That's the theory, and it works pretty well. Contraindications are many with this one as well. So persons had Viagra, Cialis, or Levitra in the last 48 hours. Their blood pressure is less than 90 systolic per national registry. And remember, it's also, the county of San Diego says it has to be above 100 systolic to provide this medication. So there are two different numbers you need to deal with here. So it has to be greater than 90 systolic for per national registry, and greater than 100 systolic for the county of San Diego to administer nitroglycerin, or to assist with it anyway. The pulse has to be between 50 and 100. That, because if you think about it, if you think about what this medication does, it reduces their preload, it reduces the amount of blood going back to the left side of the heart. If this person has a heart rate of 30 and they have a fairly decent blood pressure right now, If you give the medication, if you assist them with their nitro and it knocks out their preload, it's gonna tank their blood pressure. Because you're talking about a sick heart with a very low pulse, or a sick heart with a very high pulse does the same thing. The only that's keeping them alive is that preload, and you're going to knock it out with this medication. And of course, after that first dose, if the blood pressure drops greater than 30 points, then you don't want to give it another dose, right? Lay them down and transport. So side effects: low blood pressure, dizziness, tachycardia, and headache is probably the number one side effect, a headache. The dose. So it's you can assist up to 3 doses on standing order. That's 3 single doses. You give 1 dose, you wait 3 to 5 minutes, you assess your patient, they still have chest pain, the pressure's still okay, you then help them with the second dose, and then even a third dose. After the third dose, it would be a base hospital direction for the fourth and on. 0.4 milligrams is probably the most common dosing that you see in the field. It's given sublingually, so under the tongue, but the doses can vary. I've seen 0.3, 0.4, and even 0.6 before. It doesn't really matter. Whatever their dose is, that's their medication, you can still administer it. It doesn't have to be the 0.4 type. There's other contraindications in the white box down here. Revatio, Flolan, and Velitri all function the same as nitroglycerin. They all produce nitric oxide. They're for people who have pulmonary hypertension condition. So if they're on Revatio, Flolan, or Velitri, there's no time frame to they're on it. It would be a contraindication. And you think to yourself, okay, well, why would this person be taking Revatio, and why would the doctor give them nitroglycerin? Well, think about it. People have multiple physicians. They have one person for their pulmonary person, and then they got another person who's a cardiac person, they got a diabetic doctor, and then they got you guys get the idea. And sometimes accidents happen and things don't get crossed over, the information doesn't get transferred, and this does happen. So be careful. And again, you are the one assisting them with the medication. Your name is on your documentation. Make sure, ask the questions. Sir, ma'am, have you had Viagra, Cialis, or Levitra in the last 48 hours? Are you on Flolan, Revatio, or Velitri? You need to ask those questions. Otherwise, you're not doing a good job administering the medications. Amidose inhalers. So indication would be someone who is having bronchospasms from an asthma attack or possible bronchospasms from anaphylaxis. Either one. This is going to be their own medication. The most common medication that they're probably going to have prescribed them is albuterol sulfate. These are just some of the brand names: Ventolin, Preventolin, there's Combivent, there's all different kinds of brands out there. But ultimately, it's going to say some type of albuterol sulfate or some similar term that's going to be written on the chamber. It's a beta-2 stimulant, so it bronchodilates. Side effects are very similar to epinephrine because it's essentially epinephrine that's been slightly modified in a different form. So tachycardia, tremors, dizziness, palpitations. These people will also have a maintenance inhaler a lot of times, and these are usually anti-inflammatory medications, some type of prednisone medication. The medication administration device looks similar. The inhalers look similar. So if they hand you 2 inhalers, look and read. Like one might end in a like a ZONE on the end or something like that, and one will say sulfate, albuterol sulfate. Just make sure you're giving the right medication, because the maintenance inhalers are not rescue inhalers. They need the albuterol. You can assist with 1 dose. Now, 1 dose for albuterol might be 1 puff or 2 puffs. You need to ask the patient. So if they say I take 1 puff, then that would be your dose. You'd have to wait 3 to 5 minutes between doses. If they say 2 puffs, then you give 2 puffs in sequence. Give 1 puff, let them inhale it, let them breathe it out, let them get settled, give them the second half of the dose, the second puff. That's 1 total dose. Just document you've given 2 puffs, 1 dose. And if you have to repeat this, then any further doses are by base hospital order. Medication names. Now, usually what we encounter in the field are a generic name. Sometimes you might see the trade name on there. I know in your protocol book, you go to the back of your protocol book, there's a list of pretty much all the common medications. There's about 1,000 different medications listed in the back of your protocol book. The problem with all these things is that one medication can have multiple names. Like these 4 names here on the side here: metformin, glucophage, Fortimet, and Diabex. What you probably, hopefully, maybe I don't know, but those are all exactly the same medication. They're all a diabetic medication. It's the exact same medication. It's just different names. So it's important that you know these medications or look them up. And trust me, not every patient's going to know the medications that they take or what they're even taking them for. They're very, very much, when it comes to being informed or even being curious, it's really weird. I've gone on patients who are taking multiple medications, 3, 4, 5, 6, even 10 different medications. And you go to quiz them, they have no idea what the medications are for. They just say, well, the doctor told me to take them. It's very, very strange. So it's your job to understand what the medication is, what they use it for, and then how it affects your assessment and maybe your treatment. So different routes of administration. So sublingual under the tongue. Orally is by ingestion. Inhalation would be oxygenation, getting air into the lungs. Intramuscular would be in the thigh. That would be epinephrine. Intranasal, of course, is Narcan. It goes up the nose. Probably the fastest administration is probably going to be intramuscular. Then probably after that would be sublingual. So that's the fastest way that's going to get medication into a person's system. Different forms of medication. This isn't a big problem for EMTs. The only one big exception would be nitroglycerin. There is a liquid form versus a tablet form, but the rest of them are, you can see where, like with charcoal is a suspension, and so you need to shake that up to get it, mixed up before you can have them administer it. When it comes to the MDI inhalers, the alburyl sulfate, you'd want to take that inhaler, you want to shake it to distribute the fine particles evenly in the chamber before they push the button. That way they get a full normal dose, a full meter dose essentially. So just being aware of the medication and how you need to prep it before you administer it to the patient. Key steps. So obviously all medications, whether it's oxygen, nitro, aspirin, whatever it might be, it's all based on medical direction. It just depends whether it's a standing order or whether it's a base hospital direction. With that, so you have your order, whatever order it might be. And then we want to do your 5 right. So yes, it's the right patient. It's the right medication for this patient's condition. It's given the right route, which means it's given you orally or it's given by inhalation or by injection. It's the right dose and it's not expired. It's the right date. You're then going to turn to your partner and say, hey, partner, could you triple check it for me? And they're going to check the 5 rights as well. They're going to hand it back to you. You're going to do one final check. That's your 3rd check before administering it. Remember, the only medications that an EMT is allowed to administer in the county of San Diego are those 7 medications that either you carry on the ambulance or the patient has themselves. So if they have their own nitroglycerin, their own aspirin, their own MDI inhaler, then of course you can assist with those. Anything else you're not allowed to help them with or directly administer outside your scope of practice. When it comes to dosing, again, just as a reminder, one dose is whatever it might be based on the medication. If you are drawing up medication in a syringe, which sometimes might happen, I just want to point out that the plunger in the syringe body, the black plunger you see right there, the line closest to the tip of the syringe where the medicine comes out, that's where you measure from. So some syringes have 2 seals, some have 3 seals. It's the seal, that black line there, closest to the tip of the syringe. You can see again with the metered dose inhaler, one dose might be 2 puffs, it might be 1 puff. You need to know how much you're giving. It's important. And then of course, like with anything else, you've already assessed your patient, you've gone through, all of your patient assessment, you've determined that with your field impression, this person needs this medication. So you assess the patient, you intervene, and anytime you intervene, you reassess. It's a cycle of assess, intervene, reassess. You have this constant cycle going on all the way to the hospital. Every 3 to 5 minutes, you're reassessing the patient, rechecking their blood pressure, rechecking their vital signs, asking them, are they feeling any better, or are they feeling any worse, and documenting those trends. When it comes to documentation, I wanted to show you now, I'm sure by now you realize that pretty much all of our documentation is now done electronically through either an iPad or an ebook or Toughbook or laptop or something like that. But so I wanted to show you what good documentation might look like on those devices. So if you look at this from a chronological way, so we arrived on scene at 2200 hours in the vital sign, lower category here, and at that time, this person had a pulse of 70 at strong and regular, 20 full and effective for breathing. His blood pressure was 200/90. His room air saturation was 91%. His chest pain was 8 out of 10 scale. At 2203, I assisted them with nitroglycerin, 0.4 milligrams, given sublingually on standing order by JS, which is my initials. And then I reassessed him, and I found out that his chest pain decreased down to a 2 out of 10. And what I did is I updated my vital signs. So now after the administration at 1203, I got a heart rate, I've got respiratory, all that stuff. So now I have this continuity, chronological. I assessed, I intervened, I reassessed, and it's all documented. And this is good, proper documentation. This is what it should look like on your paperwork. Just a couple of things, just in case this wasn't covered, hopefully by your other instructors. These medications are not medications, obviously, that you guys can interact with or assist with or administer, but people are on these medications, beta blockers and blood thinners. And these unfortunately can lead to really poor outcomes on patients, especially traumatically injured patients. So beta blockers block beta. I know it sounds dumb, but if you think about it, what beta 1 does is beta 1 increases the contractility and the automaticity of the heart. It makes it beat harder and faster. So let's say this person's on a atenolol, propranolol. There's a bunch of medications out there that are beta blockers. Some end in LOL, just usually beta blockers, some don't. But ultimately, with these medications is if, let's say this person gets into a car accident and they've ruptured their liver and they're bleeding internally. Well, as you probably remember from your A&P, when someone starts losing blood, body tries to compensate, and they increase the heart rate and they increase the contractility. The problem is that because this person has beta blockers in their bloodstream, the heart's not going to be able to increase its output. It's going to be blocked from doing that. So that makes this person more prone to dying from their injuries because they can't compensate. That's a big problem for us and for them, obviously. Blood thinners. So imagine the same person has ruptured liver, they're on beta blockers and they're on blood thinning medications. Well, these are true prescription blood thinning medications. This isn't aspirin. These are the big baddies. This person's not going to be able to clot. They're not going to be able. The body's not going to be able to control their blood loss. So their heart can't pump effectively because the heart can't increase its output to compensate, at least temporarily. and wherever the bleed's coming from, there's no chance it's going to stop because they got Plavix on board or Pradaxa or Xarelto, one of those medications on board. That's why it's really important to get that information. What medications are they on? Are these medications problematic for us? Is this person going to crump really quickly because he can't control his bleed and he can't control, his shocky state? Anyway, that's all I have to say about that. And we're done.